All right, everybody, so I'm going to talk to you about the CureOM Symposium, just very briefly. Back in June, Rob and I attended this meeting in Philadelphia. CureOM is a new initiative from the Melanoma Research Foundation, and it's directed by Sarah Seelig, who you can see there in the middle. Just as an aside, on your table you should have some blue flyers for our next meeting, which is in February. And actually Sarah Seelig herself is flying over for that meeting to talk to us. So I can't stress enough, if you can get there, to come to that meeting, because she's a very interesting lady. Rob as well, who's sitting here at the front, is the UK's representative for CureOM. So if you have any questions about their work and what they do, then obviously direct that towards him. So the event was held at Thomas Jefferson University, which is the home of the medical oncologist that some of you may have heard of, Takami Sato. Also Eshelman and Gonsalves in the radiology department. You might know their names from some papers you may have read. Also the Kimmel Cancer Centre is affiliated to the Wills Eye Institute, where Carol and Jerry Shields are the ocular oncologists who train fellows from around the world, and our own Paul Rundle was trained by them as well. So the first talk that we heard was from Scott Wittman from MD Anderson, and he was reporting on what was discussed at the CureOM scientific meeting that had taken place the month before. Now I should just say, for those of you who don't know, I'm the general manager of OcuMel UK, but I don't really know anything about scientific things or medical things, so if you need me to teach you singing, I can do that. But this was all a bit of a struggle for me. I did pay lots of attention, I write lots of notes, so hopefully I can give you some idea of what was said. So he gave an overview, as I say. As a precursor, he explained a few things which did help me a lot. 85% of ocular 85% of all ocular melanomas have mutations in the GNAQ GNA11 gene. And these are activating mutations, which means, to my understanding, that they're on kind of all the time, growing and mutating and things. With other activating mutations such as BRAF and c-KIT that you might have heard of, we have therapies that could help with those mutations, but they're called inhibitor drugs. But with the GNAQ GNA11, it's more complicated. Because this is what he was telling us, because this thing called the intrinsic GTPase is damaged, and that's a really hard problem to fix, apparently. So what came out of the scientific meeting was that this guy, John Sondek, from the UNC School of Medicine, is doing something with the peptides that bind onto the GNAQ GNA11, and that's like a real novel way of dealing with this problem. So that was what he said. He also talked about how 85% of ocular melanomas that metastasize have BAP1 mutations, and that these are actually deactivating mutations. Apparently they can occur anywhere in the gene, and this guy Rauscher here is working on fixing it by using the way it binds to ASXL to turn it back on. But apparently that depends on where it is in the gene, so that may or may not work on everybody. So these were just two things that are kind of groundbreaking, novel things that were going on that he talked about. So by the way, if you have any questions about that I just said, please, please, please don't ask me, whatever you do. That is the extent of what I know, what I just told you. But obviously we are very, very privileged to have Professor Coupland here. And again, if you are coming to the Liverpool meeting in February, which I urge you to, Professor Coupland and or her team will be speaking there about the research they're doing, and that would be an ideal time to ask questions about things like that. So, the other thing you can do is go to the CureOM website, and on the left-hand side, it says Jump To, and if you go to the Eyes on a Cure page, you can see all the videos from that conference. So the first one has got Scott Woodman's talk in it. So there you go. So then we heard from Carol and Jerry Shields, who gave an insight into their work at the Wills Eye Institute. The team typically see 8 to 12 new ocular melanoma patients per week, which equates to 500 a year. they were talking about their feelings about watching and waiting small ocular melanomas to see if they have documented growth, and they were saying that they don't do that. They're also, it's interesting you're bringing up the biopsies, they were also talking about their approach being that they offer biopsies to everyone that can have one that's suitable for it. And they were quite passionate about that, and that's really what came out of it. Also, I asked them what they recommend in terms of eye appointments and things, because next September, OcuMel UK are going to be doing a new campaign which is to raise awareness in the general public, and obviously we'll be finding out from the doctors at the Guideline Development Group what we should be saying is the best thing to do. Meanwhile, I'm just asking people as I meet them, and this was what the Shield said, that you should have your pupils dilated once every 2 years if you're under 40, once a year if you're over 40. For those of you who don't know, if you dilate the pupils, I think they put in, is it drops they put in, Ruth? And it can make your eyes blurry afterwards, so I don't know if people necessarily sort of would choose to do that, but this is what the Shields think is important. And just as an aside, I recently got hold of these pictures from my dad's eye, so I just quickly wanted to share them with you. It's not really relevant to this, but I am interested in this issue of dilating the pupils. I don't know, Ruth, whether you can see from this whether these eyes were dilated or not. Can you not tell? Yeah. So my dad particularly, he had these eye photo taken in February 2008 as a routine. He was absolutely fine. In August he went back because he had symptoms, and they did it all again, and you can see it's quite startling difference. So, you know, this is obviously something that as an organisation we just need to understand what we should be thinking. Yes?
That's very fast for melanoma.
That's very fast, yeah. Yeah, must be quite unusual, I'd have thought. So obviously I guess we would have known from that his was quite aggressive. Yeah, so, okie dokie. Oh, so the next talk we had was from Dr. Sato, and he spoke about advances in adjuvant therapy. It's been touched upon by other speakers, but for those of you who don't know, it means the therapy that's given at the time of the primary treatment. Basically, his main point was that until we have a drug that shows efficacy in treating metastatic disease, we're obviously not going to have many adjuvant trials due to the kind of ethics of giving a potentially toxic drug to people that are never going to get metastatic disease. Having said all that, he is actually doing a adjuvant trial at the moment, sort of a pilot study, giving low doses of Sutent to his high-risk patients. The trial's been going on for a couple of years. It's showing promise at the moment, but obviously it needs to go on for a lot longer before we can make any sort of decisions about whether it is a good idea or not. We also heard about the study at a forthcoming ipilimumab trial at MD Anderson, which we're looking at ipilimumab just with ocular melanoma, so that's good, and in the adjuvant setting and in the metastatic setting. In the adjuvant setting, they're looking for patients that are high risk, so that in the US they use the monosomy 3 like we do, or the class system developed by Harbour and others, so it would be like class 2. In Sato's trial, the sunitinib trial that I was mentioning, he only takes people with monosomy 3 and chromosome 8 loss, is that right? That chromosome 8 thing. So, as I was saying, I thought, that's not right. So then we heard from the team from Thomas Jefferson that talk about liver metastases. So these are from the radiology department. They talked about the different treatments they've got there that they use and why they use the different treatments. It was really interesting for me to hear more about their immunoembolization that they do, because like we quite often hear of patients sort of in the community who've had these treatments and seem to get some benefit from it, so it was interesting. We actually heard from a patient there on the day who spoke, and she'd had 21 immunoembolization procedures, and she was working as a lawyer, very fit and well, and so that was really quite incredible for her. So basically, I understood from it that the embolization cuts off the blood supply to the tumours, making them more visible to the immune system, and then the immunotherapy that they put in then has more chance to work. That was my understanding. I could be wrong. In Eshelman and Gonsalves' experience, the patients who have immunoembolization rather than chemoembolization do slightly better in the rest of their body, which kind of suggests that the immunogenic agent that they're putting in has some kind of effect. But they don't really know how that's happening or why. It's just in their experience. It was also interesting to hear about their new Surspheres trial at Thomas Jefferson, because it's prospective, which is fantastic for us. They're also taking liver biopsies for DNA and blood tests before and after. It's going to be a phase 2 trial, enrolling 48 patients over 2 years. And I think, I might be wrong, Neil might tell me otherwise, it feels like it's a good thing for us that this trial is happening. One way or the other, we should be able to find out whether Surspheres is a treatment that would be good for us. The other thing they mentioned, these two people, Gonsalves and Eshelman, was the need, in their opinion, to avoid relying on CT scans of the liver when you're looking for metastatic disease, not of anywhere else, CT, just the liver, because they said that they found over the years many hundreds of examples of clear CT scans when actually somebody did have metastatic disease. They're looking to publish this information that they've got. So we're kind of trying to encourage them to do that, obviously. They talked about their recommendation for surveillance, which you can just read yourself. But it's basically MRI abdomen, 3 months initially, moving to 6 months, and then the CT chest. So I just want to qualify this here by saying that obviously I'm sure no one in this room is having this surveillance. The reason that Jefferson have this as their recommendation is because of the treatments that they offer. This is what the scanning protocol is that gets the patients to them at the right time to have the treatments that they want to give them. So it would be pointless somebody having all this surveillance if they weren't then going to go on and have treatments. As we briefly mentioned before, the guideline development group are going to be looking at the issue of what kind of surveillance patients should be having. I'm sure it probably won't be anything like this, I don't know, but they're going to look at all the different options and what they think is best. But I think it is very much led by what treatments people are going to have access to. What else did they say? Oh, and that they have 100 metastatic patients a year in that facility. So they've got quite a lot of experience clinically. So we heard from James Pingpank. I don't really need to tell you much about what he said because it was pretty much what Neil said. He was, I think he was the main investigator on that trial that Neil was telling you about, the PHP trial. The one thing he did say that, I don't know if Neil said or not, was that he thought it was very positive that when people crossed over from the best available care arm onto the PHP arm, that they still did as well as the PHP people who got it first line. That's what he said. I did write it down. He was also talking briefly about the intrahepatic that you talked about as well, the open procedure and how difficult for the patients it was, but how good it appeared to be. So obviously he's a big fan of PHP. And then we had, I'm nearly at the end, sorry. Then we had Scott Wittman again, who spoke a bit more about targeted therapies. First of all, he talked about the GNAQ again, saying that if it's signalling, if it's like stuck on, then it's signalling through multiple pathways, and he explained that there are drugs that have shown work on part of these cell processes in other cancers. So this is like the MEK and the PKC. And what they're doing at the moment in the US, they've got, he showed a really long list of phase 1 trials that are going on right now that are basically attempting to use these other drugs, but in the uveal melanoma setting. So they're all phase 1, and you'll remember from Neil's talk that that's like very early stages of this going on. But hopefully one of those, and it was a really long list, and if you go to the videos you'll see, hopefully one of those might show some kind of interesting data for us. He also mentioned a couple of growth factors that are expressed in ocular melanoma, which may be important. They're called c-Met and IGF-1R, and again, there's multiple agents to target those receptors currently in phase 1 trials. So on the day of the conference, I don't know if Rob will agree with me here, when they were talking about this, it felt very positive. It felt like there was, I think he showed, or he spoke about how many trials there were going on a couple of years ago, and it was just it was only like a couple, and then he showed this massive long list of how many are going on now, so it felt really, really positive. I could be wrong. He also talked briefly about immunotherapy and how you could combine it with targeted therapies. So if you had like a MEK inhibitor, that might give a good short-term response, and if you combine it with something like an anti-PD-1 antibody, that might give like a more durable response. And that seems to be the way a lot of the trials are going in America, kind of combining things. And then the last one was Evan Lipson, who was talking again about immunotherapy. He actually said that melanoma is the most immunogenic human cancer, and anti-CTLA-4 and PD-1 are currently being combined in a trial in Sloan Kettering, but I looked for it on the internet and I couldn't find it, so I don't know. I may be wrong there, but we can try and find out about that. While we were talking just generally to the clinicians and the scientists at this meeting, a lot of them were saying that ipilimumab they think is really good, but that it needs to be stronger, and that anti-PD-1 might be something that could be good, and they're looking to combine things. Also at Moffitt they're going to add a vaccine to that combination of anti-CTLA-4, which is ipilimumab, and anti-PD-1. And then just to finish off at the end, we had Dan Brown and Rani Ann talking, and they were talking about how we can use ablation for both hepatic and extrahepatic mets, so in the liver and in other places. And also they talked about using stereotactic radiosurgery for brain mets. That was interesting. It was very detailed, their talk, and very interesting. Obviously I can't put it across now, but if you want to go, again, I'll put the website up again for you. If you want to go and look at those talks, if you're interested in what treatments are available for the rest of the body, then please do go and have a look and watch that video, because it was very interesting. So that's Dan Brown and Rani Ann. And yeah, that was really the end of what I got from that conference. I thought it was really a really excellent thing, and I was so glad I was able to go. And hopefully that's given you a taste of what it was like, and you can find out more if you want to.